Welcome back to the deep dive. Today we're tackling something absolutely fundamental to medicine, really the blueprint behind every prescription, every treatment. We're diving into pharmacology.
Yeah, pharmacology, it's the whole story of how drugs work with, living systems. It sounds complex and, well, it can be, but it's the essential instruction manual.
Exactly. And our mission today for you listening is to really decode that language. We want to get past just knowing terms and actually understand the journey a drug takes.
That's it. We're looking at how it gets in, how it works, how it gets out, and sometimes, why things might go wrong. It's all about pharmacodynamics and pharmacokinetics.
Right. Those are the two big pillars we need to set up straight away. So first up, pharmacodynamics.
Mm-hmm.
When we talk about pharmacodynamics, we're essentially asking, what does the drug actually do to the body?
Yep. That's the mechanism of action, how it hits those receptors, the whole dose response thing. It's the drug's effect, basically.
And the flip side of that coin is pharmacokinetics.
Mhm.
Often people use that ADME acronym, right?
Exactly. Absorption, distribution, metabolism, and elimination. So pharmacokinetics asks the opposite question. What does the body do to the drug?
How does it handle it?
How does it process it, break it down, get rid of it? You really need both sides, dynamics and kinetics, to get the full picture. It's absolutely crucial for safe and effective medicine.
Okay, so before we even get into the good stuff, how drugs help, we kind of have to talk about the potential harms. Specifically, there are three really important definitions about toxicity, especially around reproduction and genetics.
Absolutely vital. These terms sound similar sometimes, but they mean very different things in terms of risk. Regulatory bodies test for these rigorously.
So what's the first one?
First is mutagenic. A mutagenic effect is one that actually changes the inheritable characteristics. We're talking about a direct mutation in the DNA.
So it messes with the actual genetic code.
Precisely. It's a change at the most fundamental level. They often test for this using things like the Ames test, usually in bacteria, to see if the substance causes DNA mutations. A mutagen raises the concern of, potentially heritable problems down the line.
Okay, so mutagenic is about changing the DNA sequence. And if that change leads to, say, uncontrolled cell growth, that brings us to the next term.
You got it. That's carcinogenic. A carcinogenic effect is one that induces malignant characteristics. Basically, it causes cancer.
Right.
Now, a lot of carcinogens are also mutagens, but the test for carcinogenicity is different. It looks for actual tumor formation, malignant changes in tissues over time.
And the third one, which comes up a lot, especially concerning pregnancy, is teratogenic.
Teratogenic. This refers specifically to an effect on development in utero during pregnancy that results in an abnormal structure or function in the developing fetus.
Like the classic thalidomide example.
Exactly like thalidomide causing those severe limb defects. The key thing here is that a teratogenic effect is about damage during development. It's typically not generally heritable in the genetic sense, unlike mutagenicity.
So the developing baby is harmed, but it doesn't necessarily mean the parent's genes or the baby's future offspring's genes are changed.
Correct. The structure gets damaged during that critical window, but the underlying DNA isn't necessarily altered in a way that gets passed on. Understanding these distinctions is absolutely critical when assessing drug safety, especially during pregnancy.
Okay, that lays some important groundwork on safety. Now let's pivot. How do drugs actually work? When we think about where drugs come from, it's not just plants and chemicals anymore, is it? It's about targeting the body's own systems.
That's really the modern view. While yes, historically drugs came from nature, today, many therapeutics are designed very specifically to interact with the large regulatory molecules already inside us.
They're designed to sort of hijack or modify the body's own communication lines.
Exactly. They mimic or block or sometimes enhance the body's natural signals.
And the main place this interaction happens is at receptors. Can you break down what these are?
Sure. Most drugs exert their effects by binding to these receptors. Think of receptors as very specific docking stations on or inside cells. They're usually large molecules, often proteins, and they're already involved in controlling vital biochemical or physiological processes.
What kind of processes?
Oh, all sorts. They could be enzymes involved in, say, how your body uses glucose, or they could be ion channels that control nerve impulses or your heart rhythm, or even transporters that recycle neurotransmitters like serotonin in your brain.
So the drug is like a specific key.
A key designed to fit a specific lock, yeah. And by fitting that lock, it influences whatever process that receptor normally controls. It's tapping into an ongoing biological conversation.
Okay, let's move into that journey then. Pharmacokinetics, Part 1. Getting the drug in and around. Absorption and distribution. The body's pretty good at keeping foreign stuff out, so just getting the drug into the bloodstream is the first challenge.
It really is, and this brings us to roots of drug administration and the big hurdle for anything you swallow. First pass metabolism.
Ah, yes, the liver's toll gate.
Pretty much. When a drug is absorbed from your stomach or intestine, the blood carrying it goes straight through the portal vein to the liver before it reaches the rest of your circulation.
And the liver is the main detox center.
Exactly. So the liver often metabolizes a significant chunk of the drug right away. This first pass can dramatically reduce the amount of active drug that actually makes it into your systemic circulation, what we call its bioavailability.
Which is why we have clever ways to sneak past liver, right? Like putting drugs under the tongue.
That's the sublingual route, or buccal, which is between the cheek and gum. It's a really neat trick.
How's it work?
Well, the lining of your mouth is rich in capillaries. The drug dissolves and diffuses directly into that capillary network. And the crucial part is, the venous blood draining from your mouth bypasses the liver initially. It goes straight into the superior vena cava and into general circulation.
So, advantages are pretty clear then.
Definitely. You get rapid absorption because of the good blood supply. The drug avoids the harsh acidic environment of the stomach, and critically, it avoids that first-pass metabolism in the liver. Plus, the pH in your mouth is relatively neutral, which helps keep many drugs stable.
But you probably can't take, like, a huge tablet this way.
No, that's a disadvantage. It's usually limited to fairly potent drugs needed in small doses, and the patient has to cooperate. You can't just swallow it. You have to let it dissolve.
And this is completely different from just injecting it, the parenteral routes.
Totally different. Parenteral means administration around the gut, typically injection.
Yeah.
Intravenous, IV, intramuscular, IM, or subcutaneous, sub-Q. This bypasses all absorption barriers, putting the drug directly into tissue or the bloodstream.
And that's essential sometimes.
Absolutely. It's necessary for drugs that are just destroyed by stomach acid, like insulin, or drugs that are very poorly absorbed from the gut, or when you need a very rapid effect, like in an emergency.
What's the downside of injecting?
Well, you have to use strict aseptic technique, sterile needles, clean site because you're breaking the skin barrier, raising infection risk. And especially with IV injections, you can get very high concentrations very quickly, which increases the risk of immediate side effects if the dose isn't spot on or the patient reacts badly.
Okay, so assuming we've administered the drug, how fast it gets absorbed depends on some basic physics, right?
Yeah, fundamentally it's about diffusion, often described by Fick's law. The key factor is the concentration gradient.
Meaning the difference in concentration.
Exactly. The bigger the difference in drug concentration between where you administered it, like the gut or muscle, and the concentration in the blood, the faster the drug will move across the membrane into the blood.
So high concentration drives faster absorption.
Yep. This is really obvious with topical drugs applied to the skin. A higher concentration formulation will generally penetrate faster.
And to keep that gradient steep, the body needs to efficiently whisk the drug away from the absorption site.
That's where blood flow is crucial. At the absorption site, say, in the muscle after an IM injection, or under the skin after a sub-Q injection, good blood flow acts like a constant sink.
It carries the drug away quickly.
Yes, it sweeps the absorbed drug away, maintaining that high concentration gradient between the injection site and the blood. This keeps the absorption going efficiently.
And if blood flow is poor,
then absorption slows right down. Think about someone in shock. Their peripheral circulation is shut down. Trying to give them a drug via IM or sub-Q injection might lead to really poor, unreliable absorption. Even absorption from the GI tract can be significantly reduced in shock. It really forces you to think about the route. Maybe IV is the only reliable option then.
All right, the drug is absorbed into the blood. Now what? It needs to get to where it needs to work. Let's talk drug distribution.
So now the drug is circulating, and it starts moving out of the bloodstream and into various tissues and organs. This distribution isn't uniform, though.
What governs where it goes?
Several things. That concentration gradient, again, local blood flow to different organs, the drug's solubility, especially its lipid solubility, and how much it binds to things like plasma proteins or tissues.
And the leakiness of the blood vessels matters too.
Hugely. Capillary permeability varies a lot. In places like the liver and spleen, the capillaries have large gaps. They're discontinuous. This lets even big molecules like plasma proteins pass through easily, which is important for their filtering and metabolic functions.
But the brain is a fortress.
The ultimate fortress. The central nervous system has the blood-brain barrier, or BBB.
What makes it such a barrier?
Brain capillaries are different. They're continuous, meaning the endothelial cells lining them are fused together with very tight junctions. There are no gaps or slit junctions for things to sneak through between the cells. Plus, glial cells wrap around the capillaries, adding another layer.
So how does anything get into the brain?
Two main ways. Either the drug has to be actively transported across the endothelial cells by specific carrier proteins the body has to sort of invite it in.
Like a levodopa for Parkinson's.
Exactly like levodopa. Or the drug has to be able to pass through the endothelial cell membranes themselves.
And what kind of drug can do that?
Lipid-soluble drugs. The cell membrane is a lipid bilayer, essentially fat. So drugs that are highly soluble in lipids can dissolve right through that membrane and get into the brain tissue.
Which is why psychiatric drugs are often quite fatty.
Generally, yes. They need to be lipophilic to cross the DBB effectively. On the other hand, drugs that are ionized, carry a charge, or are very polar, water-soluble, usually can't get through. They're repelled by the lipid membrane and blocked by the tight junctions.
So unless there's a specific transporter, water-soluble drugs are generally excluded from the brain.
That's the general rule, yeah. It's a very effective protective mechanism.
Now, we often hear this term volume of distribution, or VED, used to describe how widely a drug spreads out. It sounds like a real volume, but it's not quite, is it?
No, that's a really important point. VED is a theoretical or apparent volume. It's a calculated value that relates the total amount of drug in the body to the concentration measured in the plasma.
So what does a high or low VED actually tell us?
A very high VED suggests the drug isn't staying in the blood much. It's likely moved out extensively into other tissues, perhaps binding to muscle or fat. So the plasma concentration is low relative to the total amount in the body.
And a low VED?
A low VED usually means the drug tends to stay within the vascular compartment, the blood plasma, and maybe the interstitial fluid just outside the vessels. It doesn't distribute widely into tissues.
What keeps a drug confined to the plasma like that?
One major factor is plasma protein binding. Many drugs bind reversibly to proteins circulating in the blood, primarily albumin.
Like the anticoagulant warfarin.
Warfarin is a classic example. It's highly bound, maybe over 99%, to plasma albumin.
And why does this matter?
Because it's generally only the unbound or free fraction of the drug that's pharmacologically active. The free drug is what can leave the bloodstream, distribute into tissues, reach receptors, and be metabolized or excreted. The protein-bound drug is like a temporary reservoir. It's inactive while bound.
Okay, I can see where this is going. What happens if you add a second drug that also binds to albumin?
Potential trouble. If the second drug has a higher affinity for the same binding site on albumin, it can kick the first drug off.
It displaces it.
Exactly. Take warfarin again. If you give a patient stabilized on warfarin, another highly bound drug, maybe like certain sulfonamide antibiotics, the sulfonamide can displace warfarin from albumin.
Suddenly there's more free warfarin floating around.
Precisely. The concentration of free active warfarin can spike, maybe even double transiently. And because warfarin has what we call a narrow therapeutic index, the gap between effective dose and toxic dose is small. This sudden increase in free drug can push the patient into a dangerously over-anticoagulated state, increasing the risk of serious bleeding.
Wow, so just competing for spots on a protein can have major clinical consequences.
Absolutely. It's a classic example of a pharmacokinetic drug interaction with potentially severe outcomes.
Okay, so the drug has been absorbed, distributed, maybe bound to proteins. Now the body needs to deal with it. This brings us to the back end of pharmacokinetics, metabolism and elimination.
Right, also known as biotransformation. This is the body's chemical processing plant, primarily located in the liver, designed to convert drugs, which are often lipid-soluble, into more water-soluble forms that can be easily excreted, usually by the kidneys.
And this happens in distinct stages.
Typically, yes.
Yeah.
Talk about phase 1 and phase 2 reactions. They often happen sequentially.
What's the goal of phase 1?
Phase A reactions usually involve oxidation, reduction, or hydrolysis. The main goal is to introduce or unmask a polar functional group on the drug molecule. Them groups like hydroxyl, amido at H2, or sulfhydryl at HH.
Making it a bit more water-friendly.
Exactly. Or sometimes making it more chemically reactive, preparing it for phase 2. Now, phase I metabolism often leads to inactivation of the drug.
Well, not always.
Not always. Sometimes phase I metabolism actually activates a drug. These are called prodrugs. And sometimes the metabolite might still be active or the drug might pass through phase I unchanged.
Okay, so phase I makes a small chemical tweak. What about phase II?
Phase 2 reactions are conjugation reactions. Here, the body attaches a large, bulky, highly polar endogenous molecule to the drug, or its phase I metabolite.
Like sticking a big excrete me flag on it.
That's a great way to put it. Common conjugating molecules are things like glucuronic acid, sulfate, or acetate. The resulting conjugated drug is almost always much more water-soluble and, crucially, usually pharmacologically inactive.
And much easier for the kidneys to grab and eliminate in the urine.
Precisely. Phase 2 effectively packages the drug for disposal.
Now, the real workhorse behind a lot of that phase I metabolism is a family of enzymes called the cytochrome P450 system, right? Often abbreviated as CYPs.
Oh, absolutely central. The CYP enzymes, located mainly in the liver microsomes, are responsible for metabolizing a huge range of substances, both foreign chemicals, xenobiotics like drugs, and endogenous compounds, too.
Is it just one enzyme?
No, it's a large superfamily of related enzymes called isozymes or isoforms. But clinically, a few specific isoforms handle the bulk of drug metabolism.
Which ones are the big players?
The most important by far is CYP3A4, sometimes considered together with its close relative CYP3A5. Together, CYP3A45 are estimated to metabolize something like 36%, maybe even up to half, of all clinically used drugs.
Wow, one enzyme family doing that much work.
It's incredible. The next biggest contributor is CYP2D6, responsible for about 19% of drug metabolism. Then you have others like CYP2C9, CYP2C19, CYP1A2 that handle significant chunks too. Knowing which CYP metabolizes a drug is key.
Why is it so key? Because we don't all have the same enzymes, do we?
Exactly. This is where genetic polymorphisms come in. These are naturally occurring variations in the genes that code for these CYP enzymes. These variations mean that different people can have enzymes that work faster, slower, or not at all compared to the average person.
And this leads to huge differences in how people respond to the same drug dose.
Enormous differences. This is a cornerstone of personalized medicine. Let's take a classic example. Codeine.
The painkiller.
Yes, but codeine itself isn't very active. It's a prodrug. It needs to be metabolized by the CYP2D6 enzyme into morphine to provide pain relief.
So what happens if someone has a faulty CYP2D6 gene?
If you're what's called a poor metabolizer for CYP2D6, maybe you inherited two non-functional copies of the gene, you simply can't convert codeine to morphine effectively. For that person, codeine provides little to no pain relief. It just doesn't work.
That's fascinating. And sometimes the consequences are much more serious than just lack of effect, right? Like with clopidogrel.
Absolutely. Clopidogrel, the antiplatelet drug used to prevent heart attacks and strokes, Plavix is the brand name, is also a prodrug. It needs to be activated by a different enzyme, CYP2C19.
So similar issue if you're a poor metabolizer for CYP2C19.
Yes, and potentially much more dangerous. Poor metabolizers of CYP2C19 convert less clopidogrel to its active form. This means they get less platelet inhibition, less protection against blood clots. Studies have shown these individuals have a significantly higher risk of major adverse cardiovascular events like heart attack, stroke, or death, even while taking the standard dose of clopidogrel.
So your genes can literally determine if a life-saving drug will work for you.
It's precisely that critical. That's why genetic testing for some of these CYPs is becoming more common before prescribing certain drugs.
These same CYP enzymes are also ground zero for many drug interactions through enzyme induction and inhibition.
Yes, this is where things get really complex when patients are taking multiple medications. Let's start with enzyme inhibition.
One drug slows down the enzyme that breaks down another drug.
Exactly. An inhibitor drug decreases the activity of a specific CYP enzyme. If another drug relies on that same enzyme for its metabolism, its breakdown will be slowed.
Meaning its levels in the body will go up.
Right. The plasma concentration of the second drug increases, potentially reaching toxic levels even on a normal dose. The risk of side effects goes way up.
Are there well-known inhibitors we should watch out for?
Oh, definitely. Some are notorious. Cimetidine, an old H2 blocker for heartburn, is a potent inhibitor of several CYPs. We'll come back to a bad story involving that one. Many azole antifungal drugs, like ketoconazole, are strong inhibitors, especially of CYP3A4. Certain antibiotics, some antidepressants, HIV protease inhibitors like ritonavir,
Uh-huh.
even grapefruit juice.
Grapefruit juice, really?
Yes, compounds in grapefruit juice called furanocoumarins irreversibly inhibit CYP3A4 in the gut wall. This can dramatically increase the absorption and levels of drugs metabolized by CYP3A4, and the effect can last for days after just one glass of juice.
That's wild. What about those suicide inhibitors mentioned in the sources?
Ah, yeah. Suicide inhibitors are a special type of inhibitor. The drug itself is metabolized by the CYP enzyme, but the resulting metabolite chemically reacts with the enzyme and permanently, irreversibly inactivates it.
It takes the enzyme out completely.
Yep. The enzyme is dead, essentially. The body has to synthesize brand new enzyme protein to restore activity. Examples include ethanol estradiol in birth control pills and allopurinol for gout.
Okay, so inhibition slows metabolism down. The opposite must be enzyme induction.
Correct. Induction is where a drug increases the amount or activity of CYP enzymes. It ramps up the production line.
So it speeds up the metabolism of other drugs.
Exactly. If drug A induces the enzyme that metabolizes drug B, then drug B will be cleared from the body faster, its half-life will decrease, its plasma concentration will fall, and its therapeutic effect might be lost.
Leading to treatment failure.
Potentially, yes. The classic inducer example is the antibiotic rifampin. It's a very powerful inducer of many CYP enzymes, especially CYP3A4.
So rifampin can mess with lots of other drugs.
Oh, hugely. If a patient on warfarin starts taking rifampin, the warfarin gets metabolized much faster, the anticoagulant effect drops, and they risk forming blood clots. If someone is on oral contraceptives, rifampin can induce the enzymes that break down the contraceptive steroids, leading to potential contraceptive failure and unintended pregnancy. If someone is on methadone for opioid dependence, rifampin can speed up its metabolism so much it causes withdrawal symptoms.
Induction sounds just as dangerous as inhibition, just in a different way.
It absolutely is. Managing these interactions requires careful dose adjustments or sometimes choosing alternative drugs altogether.
Right, we've metabolized the drug. Now for the final step, drug elimination,
Yep.
getting it out of the body. This is where kinetics really comes into play.
Yes, how the body eliminates the drug determines how long its effects last and dictates how we dose it. There are two main types of elimination kinetics.
Most drugs follow.
Most drugs follow first-order kinetics. This means the rate of elimination is directly proportional to the drug concentration.
So the higher the concentration, the faster it's eliminated.
Yes, but more accurately, a constant fraction or percentage of the drug present in the body is eliminated per unit of time. So if you have 100 milligram, maybe 10%, 10 milligram is eliminated in the first hour. If you have 50 milligrams left, then 10% of that 5 milligram is eliminated in the next hour.
It slows down as the concentration drops. This leads to that exponential decay curve we see.
Precisely. But some drugs, and importantly some drugs at high concentrations, follow zero-order kinetics.
What's different about zero order?
With zero-order kinetics, the rate of elimination is constant, regardless of the drug concentration. The body eliminates a fixed amount of drug per unit of time.
Not a percentage, but a fixed quantity.
Right. The classic example is ethanol, alcohol. The enzymes that metabolize alcohol get saturated easily. Once saturated, they can only process a certain amount of alcohol per hour, say 10 grams, no matter if you have 20 grams or 200 grams in your system.
And this is dangerous because
Because the elimination system can't speed up if the concentration increases. If you keep dosing a zero-order drug, the levels can rise dramatically and unpredictably because the clearance mechanism is maxed out.
okay, these kinetics help us understand the half-life of a drug.
The half-life is fundamental. It's defined as the time required for the amount of drug in the body, or its plasma concentration, to decrease by 50%.
And this is crucial for dosing.
Absolutely crucial. The half-life tells us how long a drug will stick around and determines how often we need to give it to maintain therapeutic levels. It also tells us how long it takes to reach a stable level in the body, known as steady-state concentration, CSS.
Steady state. That's when the amount going in equals the amount going out.
Exactly. CSS is achieved when the rate of drug administration is equal to the rate of drug elimination. At steady state, the plasma concentration fluctuates around a constant average level with repeated dosing.
And how long does it take to reach steady state?
For drugs following first-order kinetics, it takes approximately 4 to 5 half-lives to reach about 94–97% of the steady-state concentration.
So if a drug has a half-life of 24 hours,
It will take about 4 to 5 days of consistent dosing to reach steady state levels in the patient's body. You can't expect the full stable effect on day 1.
What if a doctor wants to minimize the ups and downs, the peaks and troughs in the drug level between doses?
The way to reduce the amplitude of fluctuation is to give smaller doses more frequently. So instead of 100 milligrams once a day, maybe give 50 milligrams every 12 hours.
Does that change the average steady state level?
No. As long as the total daily dose remains the same, 100 milligrams per day in both cases, the average steady state concentration, CSS, will be the same. You just smooth out the peaks and valleys by dosing more often.
That's a really important practical point for dosing regimens.
Definitely. It balances keeping the drug level effective without letting it peak too high into toxicity or trough too low into ineffectiveness.
Okay, we've completed the pharmacokinetic journey ADME. Now let's flip back to the other side. Pharmacodynamics. What the drug does to the body. We touched on receptors earlier, but let's dive into how they actually signal.
Right. So the drug binds the receptor, but what happens next? The signaling mechanisms vary, and this dictates how fast the response occurs.
You have the really fast ones and the slower, more complex ones.
Exactly. The superfast system uses ionotropic receptors. These receptors are ion channels or are directly linked to them.
So binding immediately opens or closes a gate.
Pretty much. When the neurotransmitter or drug binds, it causes an almost instantaneous conformational change that opens or closes the ion channel. This changes the flow of ions across the membrane, altering the cell's electrical potential. We're talking milliseconds for the response.
Where do we see these?
The classic example is the nicotinic acetylcholine receptor at the neuromuscular junction. Acetylcholine binds, the channel opens, sodium rushes in, and the muscle contracts bang, 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 very fast.
And the slower system.
The slower, but often more versatile system uses metabotropic receptors. These aren't directly linked to channels. Instead, they're coupled to intracellular signaling pathways, usually via an intermediary molecule called a G protein.
G protein-coupled receptors, GPCRs.
The very same. When the drug binds, it activates the G protein, which then goes off and influences other effector molecules inside the cell.
Like turning on switches inside the cell.
Yeah, common effectors are enzymes like adenylase cyclase, which produces a second messenger called cyclic AMP, cAMP, or phospholipase C, which generates 2 other second messengers, IP3 and DG.
And these second messengers spread the signal.
Exactly. They amplify the initial signal and can trigger a whole cascade of downstream events, activating other enzymes, changing gene expression, altering cell function. It takes longer seconds to minutes, but allows for more complex and sustained responses.
What kind of receptors use this?
Many, many important ones. Muscarinic acetylcholine receptors, all the adrenergic receptors, alpha and beta, that respond to adrenaline and noradrenaline, they all work through G proteins and second messengers.
Okay, so the drug binds, the signal happens. But we also need to talk about how well the drug binds and activates the receptor. This is the agonism spectrum. It's not just on or off.
No, definitely not. It's a continuum. Let's start with a full agonist.
The drug that gives the maximum possible effect.
Right. A full agonist, let's call it DAY, has high affinity for the active conformation of the receptor, RA. By binding, it stabilizes that active state and elicits the maximal biological response the system is capable of.
And then there's a partial agonist.
A partial agonist, DPA, also prefers the active state over the inactive state, but not as strongly as a full agonist. So even when it occupies all the receptors at saturating concentrations, it produces a response that is less than the maximal effect achievable by a full agonist.
It have lower intrinsic activity, lower efficacy.
Precisely. It can't push the system to its absolute maximum.
Now, antagonists are blockers, right? But there are different kinds.
There are. A neutral antagonist, DONT, is the classic blocker. It binds to the receptor, often at the same site as the agonist, but has zero intrinsic activity itself. It doesn't prefer RA or RE. It binds equally to both.
So it just gets in the way.
It just occupies the receptor and prevents the agonist from binding and activating it. It blocks the action without having any effect of its own on the receptor's baseline activity.
But then there's the inverse agonist, which sounds weird.
It does sound counterintuitive. An inverse agonist preferentially binds to the inactive conformation of the receptor.
Why would that matter? Don't most receptors need an agonist to be active anyway?
Well, some receptors exhibit what's called constitutive activity. They have a certain low level of baseline activity even in the absence of any agonist. An inverse agonist binds to the inactive state and shifts the conformational equilibrium away from the active state, thereby reducing or abolishing even that baseline constitutive activity.
So it produces an effect opposite to that of an agonist by actively shutting down the receptor.
Exactly. It's not just blocking, it's actively promoting the off state.
Okay, that spectrum makes sense. Now, what happens if the body is exposed to these agonists or antagonists for a long time? The receptors don't just sit there unchanged, do they?
No, the body adapts. This is receptor regulation. If you continuously stimulate receptors with an agonist, the system often responds by becoming less sensitive.
That's desensitization, right? Or tolerance.
Desensitization, or sometimes called tachyphylaxis if it happens very quickly. It's a diminished response after repeated exposure. One fast mechanism involves chemical modification, like phosphorylation, of the receptor, making it temporarily unresponsive to the agonist even though it's still on the cell surface.
And if the stimulation continues long term.
Then you can get downregulation. This is more profound. The cell actually internalizes the receptors, pulls them inside, and often degrades them.
Yeah.
The total number of receptors available on the cell surface decreases.
So the cell becomes physically less capable of responding.
Correct. It's a way to protect itself from overstimulation.
What about the opposite? What if you block receptors continuously with an antagonist?
Then the cell might think it's not getting enough signal. In response, it can increase the number of receptors on its surface. This is upregulation.
It makes more receptors to try and catch whatever little signal might be around.
Exactly. The cell becomes hypersensitive to the agonist.
And this is why stopping certain blocker drugs suddenly can be dangerous.
Precisely. If you've been taking, say, a beta blocker for a long time, your heart cells have likely upregulated their beta receptors. If you abruptly stop the blocker, your own natural adrenaline can suddenly hit this now massive number of receptors, causing a dangerous rebound effect, like severe tachycardia or hypertension.
You have to taper off those drugs slowly.
Generally, yes, to allow the receptor numbers to readjust gradually.
Okay, all these molecular details, agonists, antagonists, regulation, ultimately determine the relationship between the dose of a drug and the clinical effect we see, the dose-response relationship.
Yes, and when we plot this relationship graphically, we need to be crystal clear about two fundamental concepts: potency and efficacy. They are not the same thing.
Let's break them down. Efficacy first.
Efficacy, often denoted as Emax, refers to the maximal effect a drug is capable of producing regardless of the dose required to achieve it. It's about how effective the drug can be. Can it fully relieve pain or only partially? Can it cure the infection or just suppress it? That's efficacy.
It's the height of the dose-response curve.
Exactly. It reflects the drug's intrinsic ability to activate the biological system.
And potency.
Potency is about the amount of drug needed to produce a given effect, usually 50% of the maximal effect. This is often quantified as the EC50, effective concentration 50%.
So potency is about dose size. A potent drug works at a low dose.
Correct. Potency reflects how tightly the drug binds to the receptor, its affinity, and how well it initiates the response. A highly potent drug produces its effect at very low concentrations.
Can you give an analogy?
Think of painkillers. Morphine might be highly efficacious. It can relieve severe pain, high Emax. But maybe drug X can achieve the same maximal pain relief, but it requires a much smaller dose than morphine. Drug X would be more potent than morphine, even if their efficacy is the same.
Or you could have a very potent drug, works at tiny doses, but its maximal effect is only mild pain relief, low efficacy.
Exactly. Potency and efficacy are independent properties. You need to know both to understand a drug's profile.
Now, we visualize these relationships using dose-response curves. There are two main types.
Yes. The graded dose-response curve is what you usually see for an individual subject or tissue preparation. It plots the magnitude of the response against increasing drug concentration or dose. It shows you the Emax and allows you to determine the EC50 for that individual.
But for safety assessment, we look at populations, right?
Right. For that, we use quantile dose-response curves. These curves plot the percentage of a population that exhibits a specific, predefined response, an all or none effect, like falling asleep or dying or achieving a cure, as the dose increases.
So it's not about how much response, but whether the response occurred in each individual.
Precisely. From quantile curves, we can determine doses like the ED50, effective dose in 50% of the population, the TD50, toxic dose in 50% of the population, and in animal studies, the LD50, lethal dose in 50% of the population.
And this leads us to the concept of the therapeutic index, TI.
The TI is traditionally calculated as the ratio of the TD50, or LD50, to the ED50. So TI equals TD50, ED50.
The idea being a bigger gap between the toxic dose and the effective dose means a safer drug.
That's the theory. A large TI suggests you'd need a much higher dose to cause toxicity than you need for the desired effect.
But the sources caution against relying too heavily on the TI as a measure of safety. Why?
Several reasons. First, the LD50 is obviously not determined in humans, and even the TD50 can be hard to define precisely for all toxic effects. But more fundamentally, the TI ratio can be misleading because it doesn't account for the slopes of the quantal dose-response curves for efficacy and toxicity.
What difference does the slope make?
If the curve for the toxic effect is very steep, it means that even a small increase in dose beyond the ED50 could suddenly cause toxicity in a large proportion of the population, even if the TD50 itself is quite far from the ED50. A shallow slope for toxicity might be safer in practice, even if the TI number is smaller.
So the TI is a rough guide at best.
It's an initial estimate, but you need to look at the full dose-response relationships and clinical experience to truly gauge a drug's safety margin. Relying solely on the TI number can give a false sense of security.
This brings us naturally to the reality that drugs do cause unwanted effects. Adverse drug reactions, ADRs.
Yep, unavoidable, unfortunately. We already discussed the really serious ones like mutagenicity and teratogenicity, but most common ADRs are more predictable.
These are often called type A reactions.
Right. Type A reactions are augmented reactions. They're basically an exaggeration of the drug's known pharmacological effect. They're dose-dependent and predictable.
Like the example given for alpha blockers.
Exactly. Alpha blockers are used to lower blood pressure by relaxing blood vessels. So a common ADR is orthostatic hypotension, getting dizzy when you stand up because your blood pressure drops too much. Another is reflex tachycardia, your heart speeding up to try and compensate for the low pressure. These aren't weird, unexpected effects. They're direct consequences of the drug doing its job, just maybe a bit too well or in the wrong place.
So anticipating these type A reactions is just part of using the drug properly.
It is. Managing them often involves adjusting the dose or being careful about posture changes, things like that.
Beyond simple side effects, things get really complex with drug-drug interactions. We already covered the pharmacokinetic ones affecting ADME, like CIP inhibition or induction.
Yes, those happen before the drug gets to the receptor. But interactions can also happen at the receptor level. These are pharmacodynamic interactions.
Like different forms of antagonism.
Exactly. We already distinguished neutral antagonists from inverse agonists, but antagonism itself can happen in different ways. Most common is pharmacologic antagonism.
That's the direct competition.
Yes. The antagonist binds to the same site on the receptor that the agonist binds to, the orthosteric site. It directly competes with and blocks the agonist from binding. This is often reversible. If you add enough agonist, you can overcome the block.
But there's another way to block the effect without blocking the binding site.
Yes, that's allosteric antagonism. Here, the antagonist binds to a different site on the receptor molecule, an allosteric site.
Away from the agonist's landing spot.
Right. Binding to this separate site causes a conformational change in the receptor that reduces the affinity of the agonist for its site, or, more commonly, reduces the ability of the bound agonist to actually activate the receptor.
So the agonist might still bind, but the on switch doesn't work properly.
Exactly. The allosteric antagonist indirectly inhibits the response without physically blocking the agonist binding site. This can sometimes be non-competitive, meaning adding more agonist can't fully overcome the inhibition.
Okay, so drugs can block each other. What about when their effects add up?
That happens frequently and can be very dangerous. A major example is additive CNS depression.
Combining things that make you sleepy or slow your breathing.
Precisely. Sedative hypnotics like benzodiazepines or barbiturates, alcohol, opioid analgesics, even some older antihistamines, they all depress the central nervous system. If you take two or more of these together, their depressant effects simply add up.
2 drinks plus a sleeping pill is much more dangerous than either alone.
Much more. This simple additive effect is a primary reason for accidental overdoses and respiratory depression when people mix CNS depressant drugs, including alcohol. It's a critical interaction to warn patients about.
We absolutely have to finish by discussing that historical example that ties together CYP inhibition and severe toxicity, the story of those antihistamines.
Ah, yes, astimazole and terfenadine. This is a tragic but incredibly important lesson in pharmacokinetics. These were popular, non-sedating antihistamines back in the day.
But they had a hidden vulnerability.
They did. Both drugs were extensively metabolized, almost exclusively, by the CYP3A4 isozyme in the liver and gut wall.
The same enzyme inhibited by grapefruit juice and certain antifungals.
And, crucially, also inhibited by drugs like the H2 blocker cimetidine and azole antifungals like ketoconazole. So if a patient taking estemazole or terfenadine was also prescribed one of these potent CYP3A4 inhibitors,
Their metabolism was blocked.
severely blocked. The levels of the parent antihistamine drug, estemazole or terfenadine, in the plasma shot up dramatically, way beyond the intended therapeutic range.
And what did these high levels do?
At these high concentrations, both drugs were found to block cardiac potassium channels, specifically the HERG channel. This delayed cardiac repolarization, prolonged the QT interval on the ECG, and led to a dangerous, potentially fatal ventricular arrhythmia called torsades de pointe.
People died because of this interaction.
Yes, sadly. There were documented cases of serious arrhythmias and death directly linked to co-administration of these antihistamines with CYP3A4 inhibitors, leading to both estemazole and terfenadine being withdrawn from the market worldwide. It was a stark demonstration of how a pharmacokinetic interaction, specifically enzyme inhibition, could have lethal pharmacodynamic consequences. It really underscored the need to understand metabolic pathways and potential inhibitors.
Wow, what a cautionary tale. So we've really journeyed through the entire life cycle of a drug today, from getting past first-pass metabolism, navigating the blood-brain barrier based on lipid solubility, undergoing that intricate phase 1 and phase 2 dance in the liver,
to understanding how genetic variations in CYP enzymes can make or break a drug's effectiveness, like with codeine or clopidogrel, and how displacing a drug like warfarin from plasma proteins can unleash toxicity.
It really drives home that personalized medicine isn't just a buzzword. It starts with deeply understanding these fundamental pharmacological mechanisms for each individual.
Absolutely. And predicting how long a drug will last, how to dose it, it all comes back to those elimination kinetics we discussed. First order versus zero order.
Right. First order being the well-behaved elimination, where a constant percentage is cleared. But zero order is the tricky one.
The tricky, easily saturated one, where a constant amount is cleared per unit time, regardless of how much is there, like that sink with the slow drain, as you said.
So here's something for you listening to think about, building on that. If a patient is taking a drug known to follow zero-order kinetics, maybe even within its therapeutic range, and their doctor thinks, let's just increase the dose a little bit to get a slightly better effect, what specific critical risk does that small dose increase pose that you wouldn't see with a first-order drug?
Think about that saturated elimination pathway. What happens when you add even a little more input?
The system can't speed up clearance to match. So that small increase in dose doesn't lead to a small proportional increase in concentration.
Exactly. Because the elimination rate is already maxed out and fixed, even a small increase in the dose can cause the plasma concentration to rise disproportionately, potentially shooting up rapidly into the toxic range. You lose the inherent safety margin that first-order kinetics provides, where clearance usually increases as concentration goes up.
A small tweak can lead to a massive, unpredictable spike.
That's the core danger of zero-order kinetics. A tiny dosing change can have dramatically amplified consequences because the elimination system has zero flexibility left. Definitely something to keep in mind when dealing with drugs that don't play by the usual rules.
A really crucial point to end on. Thank you. And that concludes our deep dive into the pharmacological blueprint.